let's talk about the public health significance of pain, the burden of pain. So we commissioned this econometric study where a group of epidemiologists, statisticians mined many of the national databases and came up with the following statistics. That by and large, the problem of pain in this country is an astounding number. 100 million Americans suffer from chronic pain. That's 37% of the U.S. adult population. I will share with you that that number, by the way, is an underestimate because it left out kids, it left out people in assisted living conditions, it left out people in the military. And so it's clearly an underestimate. We spend about $500 billion a year in direct and indirect medical expenses, $500 billion a year. That means that's more, by the way, than we spent in the entire Afghanistan war over all the years. We spend that every year in chronic pain. If you want to know the breakdown, about half of that is in direct medical expenses, the other half in indirect. We spend about $100 billion every year in just federal costs alone. That one of the other challenges that we had is that the data that we have is really inadequate. While we felt comfortable about these numbers, we couldn't dive into a lot of detail that we wanted to be able to do. So as you're going to see, there's a call for more consistent and detailed data, and that we needed a population-based strategy. When you're talking about 100 million Americans, you can't take that on using physicians alone or psychologists alone, that you really have to treat this from a public health standpoint. And I'll get back to that. And I've already kind of alluded to this, the key shortcomings of the data that we had on pain. There was problems with not understanding the details about the incidence and the prevalence, not understanding good links with treatment data, and the longitudinal data was not there as well. I'll share with you that one of the missions that I've taken back to Stanford after this is to develop a pain registry. So we rolled out one at Stanford in August of 2012. It's an open source model. I'm giving it away for free. Not going to make any money on it. We're now starting to work with other institutions to put it there. The idea is to develop an aggregated database where we can link in large numbers of patients to be able to provide information on point of care decision making, longitudinal assessment, and comparative effectiveness research. And one of my motivations for this is that when you look at fields like, for instance, cancer, when you look at the cancer field, the major strides that have been made in cancer were not necessarily made by new technologies. They were made actually by better use of old technologies. It's these incredibly large databases and registries that they developed over the years that allowed them to figure out which patient with which cancer, with which genetic profile, with which physiologic makeup was ultimately going to respond to which particular chemotherapeutic agent given in this manner. We can do the same thing in pain. We can develop these databases to be able to figure out who's most likely to respond to, Ravi's cognitive behavioral therapy or John Sorrell's acceptance and commitment therapy or a mindfulness-based stress reduction approach, and target specific treatments for specific therapies. And yes, I'm not giving credit. I know you didn't invent CBT, but Ravi and John both gave these two different approaches within Stanford for quite some time. All right. We realized that there was key shortcomings in populations that were disparately undertreated. And so there are racial disparities, there are ethnic, there are social disparities, there are gender disparities, children, the elderly, military volunteers, the list goes on. And we recognized this, we wrote extensively about this, and recognized that we had to take this on. And then as I alluded to earlier, we recognized clearly this issue of importance of prevention of pain, that it's better to prevent than it is to treat. That we needed to address this, particularly in the workplace, where a lot of these conditions occur, but also in the perioperative period. We've done a lot of research at Stanford. Happy to talk about it after this if people want to know. Where, the bottom line is about 90% of people after a major surgery will recover and do fine, but about 10% will go on to have chronic unremitting pain. And we've been able to do some regression analyses to determine what are those factors, and we find many of the factors that cause people to go on to have chronic pain has nothing to do with the injury. It has everything to do with what people bring to the injury. The biggest predictors, by the way, tend to be pre-injury history of PTSD, early life adverse events, anxiety, depression, fear of pain. All of these tend to load very, very heavily in these models, suggesting that once again it's not so much the injury, It's who you are when you get injured. I mentioned these population-based strategies, and there's some wonderful examples of where these have worked. You know, if we look at, for instance, the tobacco cessation, you know, the nicotine reduction programs that have gone on from public health, incredibly effective, incredibly effective. I think the smoking rate right now, probably don't want to quote me on this, but I think the smoking rate in Santa Clara County, where I'm living at, is only about 8%. I mean, it's just phenomenal. It works. When you look at pain, there aren't as many examples in the United States, but there are outside the U.S. And if you take Australia, for instance, back in the 1990s, they put together a public health campaign on low back pain, and it was called, I think it was Don't Take Pain Lying Down. And they put up billboards with educational information. They had things on the radio, and they found a huge drop-off in the number of workers' comp claims and the number of people out of work as a consequence of back pain injuries. It worked very effectively, and then the money dried up, and things went back to business as usual. So it can actually be effective. We made some recommendations from this public health standpoint. We argued strongly that we needed to improve the collection and reporting of data on pain, incidence and prevalence, costs of pain, effectiveness of treatment. And this one here, recommendation 2.2, this is out of the chapter 2, which was again on public health. This is the linchpin. This is the one that ties everything I'm going to say for the rest of this lecture together. So you want to remember this guy right here. We called on Kathleen Sebelius, who's the current Director of Health and Human Services, to create a comprehensive population-level strategy for pain prevention, treatment, management, and research. Bam! Right there. We said, HHS, take this on. We need a national approach to dealing with pain in this country. We needed to have coordinated efforts across the public and private sector, better agendas for developing research, improving pain assessment and management, and we needed to do this in cooperation with the Interagency Pain Research Coordinating Committee, the IPRCC. I know that's a mouthful. This IPRCC was a group that was started after the IOM to really focus on research issues in the country. I've been on this group now for a while, and I'm going to show you where we took it afterwards. And then enhance public awareness. So I'll keep coming back and referencing 2.2.